Thank you. It's a great privilege to be here. Really appreciate the invitation to be joining you and to be having this conversation with Suzanne, a colleague I respect and whose work has really informed some of my own thinking. You know, the United States is a very different social policy context than in Europe. Well, we're not bothered with a right to housing because we never signed the Universal Declaration of Human Rights in the United States. So we operate in a very different context. We also, unfortunately, it's not a statement of pride, but we have a lot of homelessness in the United States. About 0.5%, 0.5% of our population is homeless each year in the United States. And we have some subpopulations, I'll just throw out a number on there for you. We have some subpopulations, poor African American men, for example, where it's about 20 to 25% are homeless each year. Okay, so we have a severe problem in terms of a number of ways you could measure it. And one way of thinking of it is just in terms of the sheer amount of money we spend on direct homelessness assistance. I'm not talking about health care for homeless people and all that, but direct homelessness assistance is about $7 billion in the United States. So it's an industry. I'm always reminded of that when one time I was with my son. He was 4 years old at the time. We were at the grocery store, and he knows I work on homelessness. We were coming out, and he sees a homeless guy there, and he says, "Hey, my dad works for your company." And so certainly it has been a major thrust in U.S. policy for the last 10 years to think about how we can reduce homelessness, and we're doing it both with regard to long-term homelessness and short-term homelessness. And I'm going to be telling you a little bit about some of the research that has driven some of that decision-making and deliberation. But it's definitely a different context, and I want to make sure I acknowledge up front that I'm not sure that we have much to teach you in terms of the specific facts of homelessness in the United States and how they might be relevant to your situation. But perhaps there's something you can learn from our approach about thinking about it. I'll leave you to be the judge of that. Our approach to trying to think about ways of being persuasive in the political environment, because we don't have a rights-based framework. We have to rely on persuasion to get our Congress to put any money into this area. Okay, we can't point to a right. We can't point to entitlements that everyone should have this or that or the other thing. We have to rely on a whole different set of arguments. Let's see if this is advancing. There. So I just want to provide a brief little comparative context for thinking about the U.S. Versus a European context. But we have very weak social welfare protections, especially for non-disabled, long-term unemployed adults. Okay, and that's the bulk of the homeless population in the U.S. In fact, they have zero income protection whatsoever. We don't have a dole or a public welfare system of cash assistance for people who are long-term unemployed and are not disabled. Okay, and that would be the majority of the adult homeless population. So they literally have to beg, borrow, or worst case, steal if they want to get any cash in their pocket. Okay, because there is no other way for them to get any income. Even for people who are disabled, we have a particular group that's pretty disadvantaged because our disability system is based on work history. If you have a work history, then you're eligible for disability insurance should you become disabled. Unfortunately, there's one large category of people who are disabled at a young age before they have a work history. Specifically, people with a severe mental illness, people with schizophrenia or with major affective psychoses, major manic depression. This onset of this disease is between 18 and 25, primarily, for about 75% of the people. So it's before they get a work history. So they're stuck in this very low-income disability program we call SSI. And it guarantees they're 35% below the poverty level for the rest of their life, pretty much. Okay, so that's so mental illness is bad enough, but compound that with the fact that you're also not only poor, you're 35% our federal poverty level. Okay, in particular, people with substance abuse problems. Okay, they're categorically not eligible for disability. okay, because there's a moral judgment that came through in our law in 1996 when Newt Gingrich was in charge of the Congress, that threw people with drug addiction and severe alcoholism off of the disability rolls. Okay, so that has, and most of our chronically homeless people have a substance use related disability. Okay, and then lastly, just in terms of housing, we talk about the housing benefit and how you guys have access and right to a housing benefit. Well, in our country, only 25% of the people who are actually eligible for housing benefit get it because it's not an entitlement. It has to be, the Congress has to put out new vouchers. We call them Section 8 vouchers, but these vouchers have to be authorized, and they haven't authorized new ones in any substantive amount in the last 15 years. So as the population is growing, but there's no new vouchers. So only about 25%. It's basically a lottery system, essentially, of whether you can get assistance. So that's just a little context to think about, that you don't want to be poor in the United States, in case you didn't know that already. All right, so I'm going to just go through a few research projects to give you a little landscape to understand homelessness problem as we're dealing with it, and I'll try to connect them. But first of all, this is just to give you an idea. This is a graph from of a study I did a while ago in New York City. But it's interesting because it dramatizes the situation. This is the age distribution of the homeless population in a year in New York City. And it really hasn't changed all that much. I'll show you where it has changed. But essentially about 1% of New York's population is homeless each year. I mentioned 0.5% of the total U.S. population, but it's about 1% of large urban populations. And you can see that the highest risk group is actually infants, people who are 0 years of age. 4% of them are homeless. And you can see, in fact, negative slope here in terms of age. The younger you are, the more likely you are to be homeless, because homelessness among families in the United States, and about a third of the homeless are in families, is concentrated among preschool-age children. Okay? And indeed, pregnant women and women with a newborn are at the highest rate of homelessness risk among families. And so you see that illustrated there. Then once school age hits, the mothers don't have to put out cash for daycare. The kids go to school. They can work. And they can work and keep more of the money. So we see that actually poverty among families goes down in that period. And then these are the mothers associated with those kids. And then we have this other group here, which is the single adult population, which you can't really fully appreciate unless I'm going to show it this way. So this is a chart that shows the adult homeless. Remember, 85%, 88% of the households who are homeless in the U.S. are these single adult households, right? The typical thing we might think of when we think of homelessness. And what you can see is, go back to 1988, and you can see that the population had a modal age. The most common age was actually around 30, 31 years old. Okay, so relatively young group of people. And then what's happened is that each year we measure it, this curve is moving to the right. Okay, so like all of us, the population is aging and moving to the right. In fact, it's now 2011, the average age, the modal age, is 52. Okay? So interestingly, even back in 1988, the population who was experiencing homelessness, and this is when homelessness really emerged in the U.S. in a contemporary form, was in the mid-1980s. It was people born between 1954 and 1964. That's the majority of the population. So it's the second half of the post-war baby boom group. Okay? People who came of age, came into adulthood in the late 70s and early 80s. We had back-to-back recessions, okay? A very long period of sustained unemployment. A lot of young people, especially economically disadvantaged, educationally disadvantaged people, never got into the labor market over a 10-year period. Instead, they got into the drug market, selling crack cocaine, many of them, which comes with huge consequences in terms of addiction and, incarceration, having to spend time in treatment, violence, maybe death. So there was a large chunk of people who never got into a toehold into the labor market and have been essentially displaced for the rest of their lives and have been part of the American ecology essentially since. And this is the group that has defined homelessness in the United States since the mid-1980s. Now, the thing is, so their average age today is 52. Their life expectancy is only 62. So the population is actually going to disappear over the next 10 to 15 years. So it's a very interesting social context to understand. We are seeing an uptick in the under 30 population that's becoming homeless. We now have the equivalent of back-to-back recessions, this very sustained long period. We once again are seeing 25-30% unemployment among African American men in their 20s, which is exactly the same circumstances we had in the late 70s and early 80s. So there is concern that we may be creating a whole new cycle of economically displaced people as a result of what's happening. This is just to show you the U.S. population, because that was New York, but to show you that it holds nationally. So this is the U.S. population by age, but there you see the big uptick for the people 1954 to 1964. Okay, so that's just a little background so you can see large demographic picture. But another thing we were able to do is, because we have data from one thing that we do have, although we don't have the important legal context, we have lots of data about homelessness because we now have a requirement that every community has to implement an information system to track people who enter and exit the public shelter systems. And in so doing, we get an unduplicated count of the users who come in. Now, it started with Philadelphia and New York because they had the biggest systems in the country at one time. They've been doing it for quite a while. And by having that, we're able to look at the difference between people who stay for a short period of time, who are homeless for a short period of time, versus people who are homeless for a long period of time. What we learned when we did that is that, in fact, these red bars are the percentage of the single population, 80% of whom are in this group we call transitionally homeless. They're homeless for 3 weeks on average, and they come into the shelter 3 weeks on average, they leave and they don't come back. Okay? In fact, the most common length of time someone's homeless is 1 day, followed by 2 days, followed by 3 days, and so on. And why is that? Well, if you became homeless and you ended up in a Philadelphia shelter, the first thing on your mind would be, how do I get the hell out of here? Okay? What do? I'll go kiss and make up. I'll pull myself by my bootstraps. I have not fallen to this, and I'm out of here as quickly as possible, and that's what people do, because it's not a pleasant place to be. So if you can, you leave. But we have these other two groups. About 11% of the population is in and out of the shelter system repeatedly over time. They tend to come in the winter time when it's particularly cold or when they're sick, and we think this represents a big chunk of the rough sleeper, or folks who are living outdoors. And then there's another 10% who are essentially just living in the shelter system. Okay, they're there for very long periods of time. They might stay on average, in Philadelphia it's about a year, in New York they're staying on average 2 years continuously without any days out of the system. Okay, so it's a small group, but the blue bars show you how much money is being spent in terms of shelter dollars on these groups. And half of all of the bed days in the single shelter system are being spent on this small group of people. Okay, so imagine another way to think about it is if you go into a shelter on any given night, half of the beds are occupied by these people who are living there. Okay, so they're essentially treating it as though it's permanent housing, and no one would ever design a shelter to be permanent housing. It's one cot that is 18 inches from the next cot. You're in at 7 at night. You're out at 7 in the morning. Go out and don't get in any trouble while you're out there. And then the other thing is the cost structure is average $14,000 per shelter bed in the United States annually. In New York City, it's $28,000. Okay, so you can just imagine you would never design housing to look like that. So that certainly has motivated a lot of people to think, well, we could reduce the number of people in shelters by half if we could get these folks into housing that's appropriate for them. So why don't we do that? And that, in fact, began to motivate a number of localities in the United States to say, let's move these folks into permanent housing. They're relatively stable. They're living in these shelters. Why don't we try to find a more appropriate place? And so that became part of that conversation. And indeed, when you look at their characteristics, you can see that the longer they're in, going from the transitional episodic to chronic, the more likely they're to have a mental illness or a medical disability or a substance abuse problem, or any one. In fact, just based on the records, we didn't actually talk to these people, 85% of them have some disability, whether it's mental health, substance abuse, or physical disability. So clearly, these folks have a barrier to getting out. Everyone else is leaving the shelters as quick as they can, but these folks are unable to do so. Okay, as a function of their disability, as well as probably relationship issues that have been complicated by their disabilities. So, in any event, this study, when we did this a while ago, we recommended that we're sort of essentially segmenting the population. And that, on the one hand, we should be doing more prevention and quick relocation for the people who fall into homelessness on a short-term basis. We should be coming up with something that is sensitive to the needs of people who won't come into a shelter, who are living outside. And the most common program that's working in the U.S. is called the Safe Haven program. So it's designed with no rules. You have a semi-private room. It's 24 hours. And the intent is to try to build relationships with people to come in. There's no treatment requirements. You don't have to be clean and sober, and try to engage over time. And then there is the chronically homeless population, the people who are living in the shelters who are good candidates for permanent supportive housing. So that would be, in other words, a housing voucher along with support services to help them maintain and stay in that housing. So now the first major initiative in the U.S. to actually try to put people into permanent supportive housing was in New York City. I'm not sure how many of you traveled to New York City in the late 80s, early 90s, but it was bedlam. We had homeless people literally on every corner of the street, every train station, every subway station. There were some parks in Manhattan that had 1,000 people living in them. When the Census Bureau went out and counted the homeless in 1990, they found almost 11,000 people who were living outdoors in New York City. And because we planted fake homeless people out there to see if they would be counted, we found that they actually undercounted by 40%, so the number was closer to 15,000, 16,000. So it was a huge, huge problem, consistently polled as the #1 issue on voters' minds, as it does today in San Francisco and in Los Angeles. But now if you go to New York City, you actually have a hard time finding chronically homeless people, street homeless people, because they've reduced the numbers so dramatically. Last year, their count found about 2,200 relative to 16,000. So there's been a massive success in New York City. Part of it was started with this initiative where the state and the city agreed to build 3,600 units of housing specifically for homeless people with severe mental illness. Okay, and so we did a study. Advocates had been saying for many years that it's cheaper to put people in housing than have them on the street. You know, and they would compare the price of a prison bed or the cost of a shelter bed to what it costs to be in an apartment. But everyone expects advocates to say those kinds of things, and no one necessarily, the politicians don't necessarily believe them. So we said, well, let's actually find out. Let's take this group of folks who have been in this housing, find another group who didn't get into the housing, and then see what happened to them before and after the housing, and did it, in fact, was it cheaper to have them in the housing? That was the purpose of this study. So very briefly, because I don't want to spend a whole bunch of time on it, but when we followed about 10,000 people who were homeless for a 2-year period. We followed them over a 2-year period, half of whom got into the housing, half did not. But looking at the 10,000 overall, we tracked them through different systems: shelter, psychiatric hospitals, public hospitals, private hospitals paid by state insurance, the veterans hospitals, and then prison and jail. And what we found was that when you added all that up, that the average homeless person with severe mental illness in New York City was using $40,500 in services, in $1999. Okay, so it would be probably closer to $48,000 in today's terms. Okay, so $40,500 in pounds, so someone would have to help me, but that's something like 27,000 pounds, something like that, in the course of 1 year. Okay, and at the end of that year, you still have a person living in a cardboard box. All of those public expenditures, all of that time spent getting them better in the hospital, getting them from here and there, and all, and at the end of the day, they're still homeless. So it's a huge investment that's lost, and people ended up, still living on the street. About 85% of the expenditures are healthcare related. Okay, so unnecessary hospitalizations, people who they have to stay in the hospital longer because they can't be discharged. Like a typical person who would have a place to go home and recuperate, etc. So this certainly was something that caught our attention. But when you look at the folks who got housed, you see that they reduced their use of these services by about $16,200. Okay, so they got hospitalized less often, they got arrested less frequently. When they did get hospitalized or arrested, they didn't stay in jail as long and they didn't stay in the hospital as long. So they reduced their use of these services by about $16,200, okay, per person per year. And when you compare that to the cost of the housing, it's about $994 less than what was the cost of the housing. So, in other words, it was nearly break even. The housing cost $17,200, but you got $16,200 back in reduced hospitalization and shelter costs and incarceration costs. So, just to put a rounder number on it for you, the state and city of New York spend about $65 million on this program, but they get $56 million of it back in terms of reduced utilization. So it's a pretty good deal that you could, and then, of course, this is a conservative perspective on people's services use. These are only dollars we could specifically track to an individual associated with a hospitalization or incarceration. We did not include what turns out to be a very significant number in other studies, which is the ambulance cost, which is about $400 per ambulance ride. And these folks are being transported to and from the hospital by ambulance almost all the time. You know, tourists call 911, they see a homeless person on the ground, or the police, you know, they see a homeless person, they'll call 911. So you get lots of folks riding in ambulances all the time. It's like their taxi service, and at quite great expense. So we believe that, you know, if you were able to include that, we'd show that this was actually cheaper to have people housed than have them homeless. So that was important. So 95% of the costs were offset. We underestimated the savings. We didn't quantify the benefits to consumers like economists would, you know, the willingness to pay issues and the quality of life that people reconnecting with family members and friends and, you know, reconnecting with children that they have not seen since they left them, and concluded it was a sound public investment. Now, I was asked by the Bush administration in 2003 to assist them with a plan to try to take this initiative to scale on a national basis. And they said, what would it take to do that? We estimated at the time that there were 180,000 people who were chronically homeless in the United States, and that's what it would take, and that would involve these rent subsidies, $4,000 to $6,000 each, the service supports, which range from $6,000 to $13,000, depending on how it's done, and in some communities we might actually have capital costs to build new housing if there was not enough vacancies, but that turns out to be only a handful of cities in the U.S. Most cities have sufficient vacancies. So what was done? The President and the Congress increased spending on for chronic homelessness, homeless spending overall by 35%, about $400 million between 2004 and 2009. It went up actually another $100 million in 2010. 80,000 units of housing were created for rough sleepers and chronically homeless people in the U.S. in that period of time. And our federal government reported that there was a 36% decline in chronic homelessness as a result, from 180,000 to 110,000 last year. So this was a very successful program measured in terms of actual reduced amount of homelessness. And there are some cities in the United States where, in addition to New York, where the impact has been really dramatically visible in terms of reduced presence of homelessness. Some cities, unfortunately, continue to have a very big problem because they really were not out front and dealing with this in the early 90s like New York was. So you have Washington, D.C., you have Los Angeles, you have San Francisco, which have have some of the worst problems. So in any event, that's a very sort of good news piece of this. With the crisis, there's been level funding in homeless programs for the last 2 years, except with respect to homeless veterans, because we have these people coming back from Iraq and Afghanistan. There is a commitment to do 60,000 supported housing units targeting specifically homeless veterans, and we're about halfway through that commitment, 30,000, another 30,000 coming over the next 3 years. I can tell you more if you want to know about veterans. Okay, so switching gears, I just want to talk a little bit about family homelessness, because all of this attention being focused on single adults, people who were working with homeless families were feeling slighted because all this new money was coming along, but it had to be spent on these single adult homeless. And, I think it was a remarkable kind of sleight of hand that this typically undeserving poor population suddenly was getting all these resources, because typically, the chronic homeless population are not the most likable, adorable crowd, especially compared to beautiful little babies and children and who attract lots of sympathy. But nevertheless, we succeeded in sort of changing that dynamic. So a number of advocates for homeless families said, listen, there are chronically homeless families as well, and we think that we should be putting the resources for chronically homeless families. So I said, well, let's look and see if in fact that's true. Let's apply the same methodology to the data on families and see if we come up with the same result. But we knew that homeless families are different than the single adults. They have lower rates of mental illness and substance abuse. We knew that when you compare poor homeless families with poor housed families, they don't look very different from each other. And that the families are fairly homogeneous as a group. Okay? And we also knew that there were some confounders, which were that there had been a whole bunch of programs, homeless programs were frustrated. They couldn't solve the housing crisis, right? But they could build a better shelter. They could build a bigger shelter. They could put more services in it. So we ended up having more families going into shelters and staying in them longer because we designed a bunch of programs that were intended to do that. Whether or not it was the right thing, it's what people could do, and so they felt frustrated. They couldn't solve the problem, but they could build bigger, better shelters, and indeed that led to longer homelessness, and we knew that was going to create a problem in our analysis, so I'll explain in a minute. But when you once again compare these patterns, it looks similar initially. Again, most of the families, 75% of them, are in and out very quickly. They don't want to be in the shelters any more than the single adults do. They get there, they arrive with all their belongings in garbage bags, and they get out as quickly as they can. And a smaller group is actually in and out. Only about 5% are in and out repeatedly. But a larger group, 20%, are staying in the shelters for a fairly long period of time, which is not what we expect because they have lower rates of mental illness and substance abuse, so they shouldn't have the same personal barriers that are keeping them in the shelter. So what's going on? So, in fact, when we compare the groups, we don't see that same progression in terms of the longer-term homeless having more troubles. In fact, the longest-term homeless families look surprisingly higher functioning than the other groups. They have the lowest rates of child welfare involvement, lowest rates of inpatient psychiatric treatment history, or inpatient substance abuse treatment, or any one of those. And when we look at their income, half of them actually have a job compared to the other groups, and they have the lowest rate of having disability income. Okay, so something is going on here. Why is it that the families that seem to be highest functioning are staying homeless the longest? I also just want to point out what this costs. So even a short-term homeless episode of 90 days costs $12,000 for the family to be in shelter, which could have paid for an apartment for these families for a whole year. But look at these long-term homeless families who are staying homeless on average for about 14 months. It costs almost $50,000 for them to be in a shelter just for that one period of time. I mean, it was like something like 30,000 pounds, something of that nature. I can't do the math, but it's a lot of money. It's the equivalent of 5 years of free rent in an apartment. Or another way of thinking about it is 5 times as many families could have had an apartment paid for the cost of one family being in a shelter for this 1 year. Okay, so it's a huge amount of resources being spent to keep people in shelters. And what we found out is that basically, why is it happening that these people are staying? Because the programs are designed with the concept that the families are going to graduate from homelessness. And they have all sorts of curriculum in them. And so they're almost like a boarding school, a finishing school, if you will. They're selective about who can get in. They throw you out if you're a troublemaker. So imagine getting evicted from homelessness. What could be worse, right? What could be worse? But what it leads to is, of course, the people who graduate look better than the people who drop out. You know, like in high school, right? The people who graduate look a little better than the people who drop out. And so similarly, we see the same kind of thing going on. So these programs sort of were selectively creaming a group of people who at the end of the day would end up getting a housing voucher. So anyway, we concluded that policies and programs drove those stays and this concept of graduates. But it also suggested to us that there was a definite need to reform how we go about dealing with homelessness among families and short-term homelessness in general. So what I'm going to do here is just going to back up for a minute and say, so we decided, if the homeless system, to call it a system, first of all, is a misnomer because it's just a patchwork of programs hither and yon, and it's really not a system. But we decided to say, well, if we were to try to conceptualize what we're trying to do here to help families through a housing emergency, how would you put that in a framework and a planning framework and policy framework that would maximize the utility and efficiency and effectiveness of what we're doing? Okay, so essentially I'm using this little, I call it the volume by cost gradient here, because most social insurance programs run on a gradient like this, which is you want the highest number of people to go through the low cost per case intervention, because most people do not have complicated problems. And you reserve the high cost per case intervention for the relatively smaller group of people who are more complex, right? So we all know this from lots of different kinds of social insurance schemes. And so normally they're designed to incentivize people to use resources most efficiently in terms of how services are reimbursed, how the clients are reimbursed, what the co-payments are, et cetera, et cetera. So if we were to do that in the case of homelessness, the two ends of this distribution would be prevention on the one hand and supportive housing, which is a permanent voucher with intensive support services. That would be at the other end, okay? And then the emergency shelter would occupy sort of a middle ground here. So we envision that you have community-based programs that should be reaching you and effectively preventing you from becoming homeless first, and that if those fail, or if you don't access them for some reason, and you come into the shelter system, you should leave quickly. Some people stay longer, and the people who can't leave should really transition into the mainstream programs, the supported housing programs. So this is sort of the framework that we were putting around it. But looking at this, we also noticed that there was something missing. That the list of things we do around homelessness, is almost staggering. But we have health care for the homeless programs, we have shelter for the homeless, we have dental programs for the homeless, legal aid programs for the homeless. Some parts of the country we have schools for the homeless, and we have transportation programs for the homeless. But we don't have anybody whose job is to get homes for the homeless. Okay, no one gets paid to actually solve your problem. Okay, we get paid to take care of you while you're homeless and make sure that you're as happy and healthy as you can be while you're homeless, but we're not really trying to solve your problem. There was no one in our whole system who was actually getting paid to solve the problem. And so what we did was sort of came up with this concept of an overlay on the system that would focus on what Suzanne mentioned, the prevention activities that are done in the English context and in the Scottish context, that there would be a focus on, before people come into the front door of the shelter, can you be diverted? Can we help you solve the problem where you're coming from? Because 60% of these folks are coming from a family-friend conflict situation. Can we help you get back where you're from? Mediation, maybe emergency cash assistance, help you solve some debt issues, whatever the case may be. If that fails, we focus on relocation and providing you with some rental assistance, 6, 12, 18 months. So this was our initial concept. And then when the economic crisis hit in 2009 and Obama came in as president, and he got all the bad stuff of the crisis, but he gets this Christmas gift of the Stimulus Act. He gets to spend this huge amount of additional federal money, $800 billion, to try to save the economy. And one of the components that he built into that program was a new program designed on the basis of this green box. It's called the Homelessness Prevention and Rapid Rehousing Program. $1.5 billion was spent. The program's about to run out of funds right now. But it was a 3-year initiative to expand services to fund this green box because it didn't exist. And it's really amazing that 20 years of homeless assistance, all this money spent, and no one was actually doing this before. But so that's been our major experiment in the States, and we stole most of our ideas from the English system. We read all the evaluations that were done of the English prevention programs, and we love the language, the housing advice. We would never, that's not a term that we would use. What did I hear the other day at the conference? The housing options counseling, those are not phrases we would use. Or when the young person comes in and they're homeless, we'll go knock up the parents and have a door chat.
Yeah.
Okay, those are all phrases we would never use. But the same concept of working with the families, working with folks to have a plan that coming into the homeless system should not be your plan. This is not a nice place to be. It's not good for you. It's not good for your children. Bad things happen to people when they're homeless. It's not just like you're going somewhere. Lots of bad things happen to you when you're out there in that world. And so really working with people to problem solve around the issues that they're dealing with in the context of their community and their families, and not just treating them as though, oh, you're homeless? Well, come on in. We call them emergency shelters, but the emergency went out of it a long time ago. No one's treating it like it's any kind of emergency. Just say, oh yeah, come on in. So in any event, this was the conceptual framework we built around the new prevention initiative. And essentially going from a model that was built around shelter was the way you access services, and really we're putting housing stabilization is now the center. We're focused on stabilizing your housing. Shelter is one resource, but it's one resource that we're accessing, but really we're trying to network the other resources in the community to help you stabilize your housing. We're not, because what we had done is created a whole health and welfare system inside the shelters, and that you could only access if you were in the shelters, and that never made any sense. So I have other slides there, but we're running low on time. I think I'm just going to stop there, because you've been talked at a long time, and you've been so patient sitting there. So how would you like to move forward, ma'am?
Okay. Thank you very much.
Yeah.